Well, the novel influenza A H1N1 appeared in the late spring, early summer in the northern hemisphere. We first knew about it in Mexico and has become obviously a pandemic now, which is throughout all continents of the world. So you can see in this map what everybody, I mean, of course, the intensity of the red and the darker, the more affected the countries are. In the United States, the situation has changed significantly too. From June of 2009 to what's lately reported by the CDC, we can see that the intensity has increased significantly, and that now we, compared to the seasonal influenza that we have had over the past few years, we have had a continuous increase over the spring and summer in the United States. You can see in this graph, for example, that the green color represents in 2007 epidemic that we have of influenza during the normal season, which is an unusual number of cases. And in red, you can see what has been the behavior of influenza throughout the last year, and at this point in time, what has happened with H1N1. The emergence of H1N1 happened around the 15th to 17th week of the year, and you can see it here. This is what represents in Florida, where we have the normal seasonal flu, and then we go to the emergence of H1N1 in Mexico around the 17th week of the year. And then we have continued a level of baseline level that has begun to increase at the 32nd or 33rd week of the year now, where we are back to a level that's even higher than the seasonal influenza in Florida, probably associated to the amount of tourism and patients that come from different areas of the world. We see here also the data that we have in the United States, where we have a significant increase. We have 16,000 cases confirmed throughout the United States that have required hospitalization, with about 1,379 deaths reported up to mid-September of 2009. The situation in Chile is interesting because they had, in the southern hemisphere, their winter and their highest transmission for influenza-like illnesses during our summer months. So they have experienced a significant increase in the number of cases throughout these months. So basically during the months of May and June of 2009, we can see in the graphics where, compared to 2007 and 2008, 2009 has a significant peak associated to influenza A H1N1. And they were having significant problems in their ICUs as their resources were significantly being consumed and in some occasions near depletion to be able to treat these patients. One of the most significant things that came out from the group in Chile that's very interesting for us is that they started using a novel methodology. It's new for adults, which is the high-frequency oscillatory ventilation to treat these patients. So the patients that they found refractory to their conventional ventilation and their APRV, which are the most common methodologies used there, they move quickly into other alternatives of treatment. Some groups tried extracorporeal membrane oxygenation and pronation with different results. Some groups, like the one from the Indisa Clinic and Del Salvador Hospital in Santiago, tried one of the ventilators that they had there available, which is the high-frequency oscillatory ventilation. So the interesting situation was in Santiago de Chile, in the downtown area of the capital, where at the Indisa Clinic and the Hospital Del Salvador, they were using, for them, a novel methodology with high-frequency oscillatory ventilation. They saw in those early phases, and they have seen more patients, but at least the records that we have so far are from 14 patients that were treated with this modality that were refractory to conventional ventilation and APRV. And they were able to be recruited with high-frequency oscillatory ventilation. The pressures, as we will discuss later, were higher than the usual pressures, but these patients responded adequately And out of 14 patients, they only had 2 deaths in refractory patients. So you can see here, this is a sequence of x-rays provided by Dr. Sebastián Ugarte from this clinic that shows the patient, as it was seen during admissions, with a very dense bilateral multifocal infiltrate, to what happened after 6 hours after the recruitment and continuous positive airway pressure of this nature, and the patient on the next day after 24 hours. We show a striking difference in the x-rays, throughout this 24-hour period. These patients normally require 10 to 14 days of oscillatory ventilation before they could be moved to conventional ventilation. But out of 14, only they had 2 patients that were lost in this situation. The theory behind high-frequency ventilation can be explained as follows. The lung is a very stable structure during inspiration and expiration. We see here the images taken from a rat lung using in vivo video microscopy, and you see that during inspiration and expiration of a ventilated lung, the alveoli remain very stable, with very little change in their size throughout the cycle. And we have learned with time that the lung doesn't want to be overstretched and doesn't want also to be collapsed during expiration. When the lung is injured, it becomes a very unstable structure. And throughout the years, we have learned that the ventilation should probably be aimed to keeping the lung as stable as possible. How have we done that with conventional ventilation and APRV? Is by establishing limits to our ventilation. We don't want to overstretch the lung, having plateau pressures that are higher than 30 centimeters of water. We don't want to go below the recruitment pressure to prevent the collapse of the alveoli during the expiratory phase. And as we see here, we try to then obtain what's the best PEEP, the positive end expiratory pressure, to prevent the lung collapse during expiration. And we try to limit ourselves, our titling, to the plateau pressure of about 30 centimeters to prevent overstretching of the lung. So the idea is that if you go below or beyond these limits, that you go to areas of injury where you can, by ventilating the lung, going over these areas, you can generate even further injury to a lung, what we recognize now as ventilator-induced lung injury. The theory behind oscillation is that we could probably remain between these 2 set limits with much smaller tidal volumes, almost like a wiggle of the lung, and prevent the pressures that could overstretch or under-recruit the lung and remain in a very safe area for the lung as it is. As we can see here, these are alveoli, again, of a rat model, where you can see that with a mean airway pressure of 25 and a PEEP of 15, it is not enough to keep this lung recruited. This is a lung that during the expiratory phase, due to its injury, is unstable, and you can see alveolar sacs collapsing and expanding during the inspiratory and expiratory cycles. This is also a rat lung during APRV, and you can see even though the P low, it has a T low of about 0.4, 0.5 seconds, there's a collapse of the alveolar structures during the expiratory phase, during the volume release. That's probably because we are going below the pressure that keeps the lung open in the expiratory phase. Now compare this to this video of high-frequency oscillatory ventilation, where you see the alveolar structures much more stable, with essentially quivering, with no significant collapse or expansion during the expiratory or inspiratory phases of the cycle. This appears to be more consistent with what we normally see during the normal functioning of the lung. These patients traditionally are managed in a stepped sequence where we start with volume ventilation with low tidal volumes, higher PEEP, based on the recommendations of the ARMA trial of the ARDS network from the year 2000. If that would fail, I mean, most people probably move to pressure control ventilation with higher PEEP and even reverse IE ratios. Some people can move to non-conventional types of ventilation like APRV or high-frequency oscillatory ventilation. And in the centers that are trained and prepared to do so, they may even use extracorporeal membrane oxygenation to support this patient in view of the complete respiratory failure. When do we consider moving to high-frequency oscillatory ventilation? We have had, fortunately, very good experience with this, and we move probably a little earlier than most people do. The way we move is, if the patient's doing well, like most of the patients will, with the ARDS network protocol, then we stay there. But if we see that the FiO2 requirements are higher than 60% or 0.6, if we see that the plateau pressures are higher than 30 in order to keep adequate ventilation, if we see that we have a mean airway pressure of higher than 20 or a PEEP higher than 15 or an oxygenation index higher than 15 as well, then we move to high-frequency oscillatory ventilation. How do we start high-frequency oscillatory ventilation? The initial settings of our ventilator consist of an FiO2 of 1 with an amplitude of 60 to 90 centimeters of water to have our wiggling factor, to shake the chest and the lung. We start with a bias flow of 30 liters per minute that may be increased depending on how much you need to maintain your mean airway pressure. We start with a frequency of 5 and with an I time of 33%. With these, as we change the patient to the oscillator, we do a recruitment maneuver of 40 centimeters for 40 seconds. And after we have done this recruitment period, we come back down to a 30 centimeter mean airway pressure as we start the oscillation. We want to see at this point in time that the saturations of the patients have increased. Normally, we would have patients with very abnormal saturations in the low 80s or mid 70s or even worse. And our recruitment maneuver should be seeing an improvement in that oxygenation as we do the maneuver. We should see saturations that quickly go to the mid 90s or high 90s as we recruit the lung. After we have held that for a period of 40 seconds, then we go down to mean airway pressure of 30 and we start the oscillation. If within the next 20 minutes we don't see a significant increase in the oxygenation of this patient, which is clinically seen as a capability to decrease the FiO2 to 0.6, then we perform a second recruitment maneuver of 40 centimeters for 40 seconds. But instead of coming back down to a pressure of 30, we come back down to a pressure of 35, and you see in the diagram. And after 20 minutes, if we don't see a significant improvement on oxygenation as well, then we may proceed to a third recruitment maneuver, which usually is between a pressure of 45 to 50 for 40 seconds. But instead of coming back down to a pressure of 35, we stop at 40 and leave that there because that may be the recruitment pressure that we require for that patient. We have seen in most of our patients, we use pressure between 30 and 35. We have seen that with H1N1, we have had to use even higher pressures for these patients in the range of 40 to 45 in order to open the lung and have adequate oxygenation. This is a significant increase in severity of these patients compared to our usual population that requires this modality of ventilation. Now, this is all based on the TOOLS trial. This was published by the group in Canada led by Neil Ferguson in 2005 in Critical Care Medicine. How do we support these patients? Well, these patients have to be deeply sedated. They cannot breathe on their own or have any respiratory drive, because if they breathe on their own, they will start generating negative pressures and collapsing the airway. In some cases, at least for the first day or two, they may require, as they improve, neuromuscular blockers that can stop the breathing at this point in time, obviously with adequate sedation. The suctioning is also very important. I mean, we try to suction them as little as possible, at least during the first 24 to 48 hours, to prevent the generation of negative pressures that would require a recruitment. If you need to do it, we do it, but we try to limit as much as possible the suctioning of these patients. And then, at least from the reports from the groups in Canada, from Manitoba, they have seen that these patients have done well with very limited intravenous fluids. We don't want to make sure that the perfusion happens adequately, that the kidneys are perfused, that our organs are perfused, but over-perfusing these patients, over-hydrating these patients has been seen with a worsening of their oxygenation, possibly because of the appearance of edema in the lung, again, from too much excessive fluid. This has been essentially the recommendations that we have had for the management. Now, once these patients are able to be weaned to certain parameters, we can transition these patients from high-frequency oscillation to conventional ventilation. How do we do that? Well, first of all, in order to have some range, some safety for moving these patients to lower parameters, we want to make sure that we have some room with the oxygenation. So we consider that the recruitment maneuvers were effective when we're able to decrease the FiO2 to 0.6. We start weaning the pressure once we have kept an adequate oxygenation with an FiO2 of 0.4. So we wean first the FiO2 to 0.4. Once we have reached 0.4, very slowly we start decreasing the pressure. The idea of this is that the pressure changes have to be done very carefully. You don't want to move too quickly and then have to go back and re-recruit the lung. And you want to assure that in every step of the way, you are moving the patient in the right direction without precipitating, a closing of the alveoli. So once you reach an FiO2 of 0.4, we decrease in 2 centimeters the pressure from whatever we were. Let's say we were at 34, then we'll go to 32. Between 4 and 6 hours later, we may attempt going to 32, as long as the patient continues to have adequate oxygenation. Once we have reached with our pressures a level of 20 to 22 centimeters of water, then we transition to a more conventional mode of ventilation. We go to pressure control ventilation with an FiO2 of 0.4, with an inspiratory pressure of 30 and a PEEP of 15, having a driving pressure then of 15 as well, and a 1-to-1 I/E ratio, and a rate of 20. That would be our first transition. These patients are transitioned from the oscillator to conventional ventilation with these settings. We observe them for the next 20 minutes, 30 minutes to make sure that the saturations and that the oxygenation and CO2 removal all stay within the acceptable limits. If we see problems within the next 20 minutes, they will have to be returned back to high-frequency oscillatory ventilation.